Yes, doctor. Go ahead. Go ahead.
Yes. So I'll be presenting a patient's name, Ayatsuma. She's a 65-year-old female patient. She came with a chief complaint of discoloration of the skin in the dorsum of the right hand since 3 weeks. She's a known case of a breast carcinoma, stage 4. She had underwent modified radical mastectomy and she was taking chemotherapy, passed in 2008. She later had right side hip pain, and for the same she underwent MRI later, which the MRI suggested to have a acetabular and L5 vertebral collapse with thecal compression. She For this she was advised radiotherapy, and during the admission she had an IV cannulation in the dorsum of right hand for IV injections. With this cannulation site, there was extravasation of the injection, because of which she developed edema and pain in the dorsum of the hand, which was initially treated conservatively. Later, she noticed discoloration of the skin since 2 weeks, which is gradually progressive, not associated with any discharge. Now she presented for further management of the same. There is no history of any other comorbidities or no addiction of any other substances. This is elderly women, moderately built and nourished, conscious, cooperative, no ecta, pallor, cyanosis, clubbing, lymphadenopathy, or generalized edema. The vitals were stable. Systemic examination were within normal limits. Coming to local examination, right upper limb examination in the inspectory findings. She was examined in sitting posture with elbows flexed at 90 degrees and hand in neutral position, with hand in prone position. There was a necrotic patch in the dorsum of a hand just abutting the wrist of size of 6x4 centimeter, length by breadth, with visible necros subcutaneous tissue in the proximal and distal border, extending from the distal carpal bones to the mid shaft of second to fifth metacarpal. Medially, it was extending from the second mid shaft to the fifth mid shaft of the metacarpal, mid-shaft metacarpal. Range of movements, there was the range of movements across all the joints was normal in both active and passive range of movements, and there was no neurosensory deficit. The surrounding skin was normal. There was no regional lymphadenopathy. Allen's was positive. That's like both radial and ulnar artery was intact. Proximal forearm and arm, there was no scars. Groin and thigh, there was no scars. Or no signs of previous skin grafting. The diagnosis: it's elderly female, post radical modified radical mastectomy, with post extravasation necrotic skin dorsum of right hand with normal range of movements and no neurosensory deficits. The management, first I would like to investigate her for routine blood investigations as well. Take the x-ray of the hand, the AP and oblique, to rule out if there is any mess. And also I would like to go with a Doppler just to know if there is any arterial abnormality. Surgery, so I had planned for a debridement of the necrotic patch with surrounding scarred area, and decide post the debridement, I'll be deciding whether to go for a skin graft or regional or distal flap cover, either under axillary block or so if it is a posterior intraosseous flap, so I'll be going under axillary block, sir. So this is the defect of the flap post post the debridement, which is exposing the tendons of the extensors of the third, fourth, and the second to third, second, third, fourth extensor is visible. So there is no paratenon. I wouldn't go with a skin graft, so I would plan for a flap. So my first plan is a posterior intraosseous artery flap.
Anita, can you just go back? Go back to the slide. Yeah. You said no distal no sensory deficit. Hello? Can you hear me?
Yes.
Can you hear me? Hello? Hello.
Anita?
I hear you. Hello.
Can you hear me?
Hello? Yes, sir, I can hear you, sir.
You said no distal sensory deficit.
Deficit. Yes, sir.
Now, after your debridement, do you think there will be distal sensory deficit?
So I can see the nerve in
They're all
the
intact?
medial in the lateral. It looks intact, sir.
Okay. So you have preserved the radial and ulnar sensory nerves.
Yes, sir.
Okay. Okay, go ahead.
Okay. So my plan is for my first plan is a posterior interosseous artery flap. I decided this flap because I want to preserve the radial artery, which is the I don't want to sacrifice a major artery of the hand. So I went ahead with the posterior interosseous flap. So the axis of the flap is from the lateral epicondyle to the distal radio-ulnar joint. So this will be the axis of the flap, and the pivot point is just 2 centimeter proximal to this point, where this is the point where the anterior interosseous artery and the posterior, there'll be anastomosis between the anterior interosseous artery and the posterior interosseous artery, as well as the flap can reach the defect which has been given to me. So I would go ahead with this, and after the debridement, I would mark. The largest perforator is in the line between the epicondylar styloid, epicondylar distal radio-ulnar joint. In midpoint of that, just this 1 centimeter distal to that will be a large perforator. So I would try to base my flap around that, and I would I would go ahead with the incision. Like first, I'll go ahead with the manual exsanguination of the hand, um, and then I will proceed with the dissection um, from the ulnar aspect. Then I come to the from the ulnar aspect in just the skin and the just to up to the fascia, and then I go ahead uh, into the lateral aspect, and then distally, and then I go up to the pivot point. Here I identify the extensor digiti minimi and the extensor carpi ulnaris. The posterior interosseous artery lies between intermuscular septum between that. So I will try to preserve the perforator, and I will go ahead with the dissection. Once further ahead, I will once the distal point, that is 2 centimeter above it, I will try to find the at that point I will check the reach of the flap. If the reach of the flap is okay, then I go ahead and tunnel the flap, and then I'll give the insert to the raw area. So
Just a
the
minute. No,
yes, sir.
you
Yes, sir.
said you will dissect up to the pivot point and
Yes, sir.
see for the reach. That's what you said, no?
Uh, Sir, no, sir. I will go. Initially, I would have marked the point from the defect to the pivot point. I'll just check from there. I will actually go from the pivot point to the distal edge. The same, how much the length of the defect from the defect to the pivot
So
point. The from
go
the
back.
pivot point to the
Can you go
distal.
back to that picture, the defect picture? So you don't have the entire forearm.
No, sir. I don't have.
So so how do you plan in reverse for this?
Sure. Um, First, the distal edge of the defect to the pivot point. I take that as the length. From that pivot point to the, I just go ahead with the same length into the same length. I'll mark a point that becomes my distal end of the flap, and the proximal end will be like I'll take with the help of a lint, I'll take the defect and I'll reciprocate it in the forearm. That will be that will be the length and breadth of the flap, which I'll have to be taking from here till the pivot point I reach, and then I will tunnel it into the defect. So that will be the length of the pedicle which I'll be getting.
So you want to tunnel it?
Yes, sir.
I am scared of tunneling, especially post-interosseous artery flap. So what all you can do? I don't want to tunnel it.
So either I can give an incision distal to it and and put a flap over it, put a graft over it, or
Any other modifications you've seen or come across people doing it?
the pedicle.
Huh?
Um, uh,
All along the pedicle, you extend the skin like a racket.
yeah, just the skin and the epidermis, and not go on up to the subcutaneous fat, and then.
So you incise it and lay that and suture the skin.
Yes.
So you don't put a graft.
Yes.
Okay, especially post-interosseous, people do tunnel it, but sometimes, especially in the elderly, you don't want any
Vascular
compromise. So with so much of comorbid conditions, you want a definitive plan. You don't want take any risk. Such cases, don't tunnel it. Straight away,
Yes,
open it, and maybe you can take like a racket handle. You can take an extension all along the pedicle.
Yes.
Okay.
Yes,
So this is your first plan, post-interosseous artery.
yes, sir. Yes, sir.
Who described this?
Uh, uh,
What was his original description, and what is the currently followed one?
sir, he discovered.
Huh? Hello.
Yes, sir. Uh, sir, I forgot. I don't know, sir.
Don't know.
No, sir.
Don't give credit to people who discover these things. Huh?
Sir, I read it. I forgot. There were two. Actually, it was modified by found by
Why?
someone modified.
Why? Initially, where was the flap? Main flap was placed. The original description.
Yes,
The
sir.
skin paddle was taken from where?
From the.
So where
Distal
post-interosseous
last.
artery? Post-interosseous artery is
Yes,
a
sir.
branch of
Ulnar artery, sir. Ulnar artery at the level of the radial tuberosity, it gives gives two branches, anterior interosseous and posterior interosseous.
so that anastomosis will
Uh,
it comes to the back of the forearm.
yes, sir.
Anastomosis with what artery?
Sir, I didn't get. It
Have you read about anastomosis
proximally.
around the elbow? Have you read about anastomosis around
Recurrent.
the elbow?
Yes, sir.
Uh, how are the anastomos?
Either through a recurrent.
What is lateral arm flap pedicle?
Recurrent.
Lateral arm flap, you heard?
Yes, sir.
So extended lateral arm, how do they take?
Um,
Heard about extended lateral arm flap?
yes, sir.
So where is the extension?
Right. Posterior radial collat.
The same thing, anastomosis with the posterior interosseous here.
Posterior interosseous artery.
Actually, the initial skin paddle was very close to the elbow, upper third.
Okay. Okay,
Subsequent
sir.
modifications
Yeah.
only, they saw a lot of good perforators along the middle. So subsequently, they didn't go higher up. Go more higher up. What is the problem?
So the vast, it is not, there is chances of necrosis of the distal flap, sir, like the
More than
proximal flap.
that, the posterior process no. All the
The posterior
branches of the posterior
extends
process
the
no.
yeah.
So you will have to carefully dissect at that level. So that's why as you come lower down, they're all given the branches. You have only a single
Yes, sir.
nerve going down. So that is one big advantage with the modified posterior process flap. So of course, this is your first plan. What is the next plan?
So our
She is
next,
not
my
fit for
plan
any.
was,
She is not fit for any major surgery. She has so many comorbid conditions. She is just recovering from chemotherapy. She has to undergo some more chemotherapy. I think her chemotherapy is not over, no?
she had finished it. Now she's undergoing a palliative radiotherapy, sir.
So the treatment is going on. So you cannot
Yes, sir.
interrupt the treatment. So I
Yes,
don't
sir.
want her to undergo any major procedure where you will have to keep her 1 or 2 weeks, watch her and all those things. So you
I'll put,
deprive, huh?
I'll put a vac therapy for her and skin graft.
So will VAC help in her?
So the tendon is exposed.
Even then, will VAC will help?
Sir, no, sir, because the chances of granulation is lesser.
In fact, VAC will help. And here we are not thinking about
Post-operative
uh,
radiotherapy.
uh, post-operative radiotherapy or whatever it is. So you can buy some time. Suppose if they are continuing some treatment, VAC will help you to buy some time. You see, you want to apply 1 or 2 VACs, see whether the granulation is coming or not, whether it is covering the tendons or not. And is extensor tendon very important for function of the hand?
The
Huh?
flexors are more important. Flexors are more
So
important.
you can just divide that and remove all the extensor and put a graft.
Yes, sir.
And then why do you want to do a major flap surgery?
So I will actually, no, sir.
Pardon? So this is your second plan, groin flap.
Yes, sir.
How old is she?
64 years, sir.
65 and undergoing radiotherapy. You want to give a groin flap. Which is ideal flap for dorsum of the hand?
The reverse radial.
No, no, no. The pedicle flap. Groin flap is ideal or abdominal flap is ideal?
Abdominal flap.
Which is ideal?
Groin.
Of course, groin can be given to any defect in the hand. There's no controversy in that. But which is when given a situation between a groin flap and abdominal flap for a dorsal defect, which one will you choose?
Abdominal.
Then why you have marked groin flap? Huh? So no harm.
Have you
Groin
brought
flap.
the abdominal flap also?
Pardon?
No, 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 ma'am. I haven't planned for it.
Okay. So groin or abdomen was your second choice. Third choice?
Um, reverse radial, sir.
Reverse radial. Okay.
And then free flap.
Free flap. So you have given all options. You have to think
Plantar
about
flap
all. You have to think about all the other comorbid conditions.
comorbidity.
If it is trauma, yes, okay. You can list out 1, 2, 3, like free flap to free flaps. When they have so much of comorbid conditions, you must try to quickly heal them and try to send back to their You have to continue the treatment. So just try to do the minimum, especially there will have a lot of other issues also. You got to be careful in choosing your, of course, if the vascularity is all right for the upper limb, posterior intraosseous is the ideal first choice. There's no doubt about it. And if both, you said, Alan, you want a more robust flap, then probably radial artery is ideal. And definitely not a groin flap in a 60-year-old undergoing chemotherapy, radiotherapy. It's not ideal. Yeah. Shoulder, elbow, hand, everything will become stiff by the time you divide. Normally, when do you divide?
After 3 weeks.
Straight away divide?
So delay and then
How do you do a delay?
go up to the fascia and then divide it.
So here what you do? You mark a groin flap and you mark a nice artery also. How do you do a delay in this?
So the pet.
I'm not able to hear you. Hello?
Hello, sir. Can you hear me now, sir?
Yeah. Do you do a delay or
along
not?
the pedicle, along the pedicle.
So you look for the pedicle and do a division of that pedicle artery, or you just randomly cut 50% or 75% and suture it.
So look for the pedicle and.
So how much percentage of insert you have given in this? Go to the defect.
So my mic is activated now, sir, because projecting this right, I couldn't go back and deactivate it.
So how much of insert you will give it this?
Now it's on. I couldn't go to the same.
How much of insert
sir.
you will give in this situation?
So almost 3/4.
More than 75% insert you would have given. Am I correct?
Yes, sir. Yes,
Can
sir.
you straight away divide without doing a delay?
Yes, sir.
So you can. So that is also possible. Okay.
Yes, sir. Yes, sir.
So that's why when you are giving an insert, you try to give as much as possible. And moreover, the flap also will be nicely adapted to the bed. It is not like a tubed groin flap which you are giving for thumb defect or finger defect. So here you have a very broad attachment. So nearly the 3/4 edge you suture it, and the bed house also will be nicely stuck.
Vascular.
So straight away you can divide it. And if the pedicle is little tube, you can train the flap. Suppose you have done a tubing or narrowed all the raw areas, sutured the pedicle, formed as a tube. What will you do after when the flap is nicely settled after 2 weeks or so? Will you train the flap? Hello?
Yes, sir.
Can you do some training of the flap?
Yes, sir.
Can you ligate the base temporarily for
of the vessel? Yes, sir. We can ligate the vessel temporarily.
Not the vessels. Take a rubber tube and tie it near the pedicle. Train the flap. So day one you do it at 5 minutes, 10 minutes, tie it and remove it like that a couple of times, 3 or 4 times in a day, and gradually increase it to 20 minutes, 30 minutes. If there is no ischemia, straight away, at the end of 3 weeks, you can go and divide the flap. Okay?
Yes, sir.
I think Sandeep Lakshmi will stop with this.